And so our final speaker is Patsy Brannan. Dr. Brannan is currently visiting professor and was professor until her retirement in June of 2018 in the Division of Nutritional Sciences at Cornell University. She was a member of the National Academies committees on dietary reference intakes for vitamin D and calcium, and on dietary reference intakes for sodium and potassium, as well as the National Academies Food and Nutrition Board. Dr. Brannan?
Thank you very much. I appreciate being invited to be a part of this workshop, and like the other speakers today, have found the sessions before quite intriguing and thought-provoking. You've heard my disclosures as a part of my introduction. What I hope to do in my 15 minutes with you is explore opportunities and challenges for incorporating precision nutrition into public health approaches, such as the dietary reference intakes and the dietary guidelines. And I want to focus some of these comments on adequacy related to the DRIs and on chronic disease, both in terms of the DRIs and the chronic disease risk reduction, and in terms of dietary patterns and dietary guidelines. I want to thank Dr. Roberto for covering dietary guidelines in such depth, because I'm going to touch on them and not have as much depth. I also want to address some issues related to subgroup populations, which have come up in both of the previous sessions. And I want to then move to considering opportunities and challenges for incorporating precision nutrition into what I'm going to call individual guidelines or recommendations. And then I want to conclude by reflecting on blended models that might think about how we might proceed forward with both public health and individualized models. And as I listened to the presentations and the discussion and thought about what I had read before, it seems to me that as we think about this, we need to keep in mind that public health guidelines inform population-based policies and regulatory actions. And these include a diverse array of federal nutrition programs, nutrition labeling, population assessment done by a variety of levels of government and health researchers. Whereas individualized recommendations, as you've heard numerous speakers comment, tailor nutrient and dietary intake and dietary patterns and status assessment for the uniqueness of an individual. Public health guidelines, therefore, are implemented through national outreach, education, policies, regulations, and fortification, population monitoring, and assessment. And as you've heard, there are limitations of this, quote, one size fits all, but there are also some necessary features of this, because to try to do individualized recommendations and assess the status of the population would be a very big data challenge if we had the science to support it right now. When we're implementing individualized recommendations, we're really talking about an individual interaction with either technology, I'm going to call this the tech model, or supported technology and a health professional. The hybrid model that we heard is more effective. And I want to echo some comments that the previous speakers have made about individual action. And I'm going to call this the self-directed model, because I do not think we are going to move forward in this space without individuals choosing to cherry pick information that's available to them from a variety of online sources without necessarily engaging with either supported technology, the tech model, or with the hybrid model, and that this pick and choosing is going to open up individuals to misinformation as well. And I think that's something we need to keep in mind as we move forward. Public health guidelines have to account for the wide variation that all of our speakers have talked about across a generally healthy population. I've italicized generally healthy because there's a lot of debate about what this is when 60% of your population has chronic disease. And it's something I want to touch on later. And in terms of this variability is in terms of individual needs, their risks, their preferences, their behaviors, and their environment. In contrast, the individual recommendations hold the great promise of being able to address an individual's unique needs, their risks, their preferences, their behaviors, their environments, and their status. And this is something that we clearly need as we work with individuals as opposed to the population as a whole. Public health guidelines require moderate to high strength evidence because of the risk to the population. And I'm going to submit to you that individualized recommendations are going to require at least moderate strength evidence in either the tech model or the hybrid model. But in the self-directed model, because of the nature of the way in which an individual might acquire their information, might self-select, cherry pick, might rely on their own personal opinion, that level of evidence might be quite a bit lower, and therefore the risk might be higher. And it's important to recognize that public health guidelines exclude those specifically with diseases that require medical nutrition therapy or diseases that alter needs due to malabsorption, dialysis, disability, or altered mobility. But that individualized recommendations might be able to include such individuals as they tailor the diet. It's uncertain, though, how individual guidelines will be blended with medical nutrition therapy and how this will be monitored and in what settings and under what conditions. Now, I know all of you are familiar with the dietary reference intakes. I want to take a minute and just review the expanded DRI model that now includes the chronic disease risk reduction, the CDRR, and can consider chronic disease outcomes. One thing that's changed is that when we talk about estimating the median need of the population, the estimated average requirement for a normally distributed nutrient, or a mean for a non-normally distributed nutrient, we are now looking at an adequacy outcome. No longer can a chronic disease outcome be considered. And when we look at the upper level, tolerable upper level, we're now looking at a toxicological outcome. No longer can a chronic disease outcome be considered. And embedded in this model is the notion of distribution of need. And I've imposed upon here a normal distribution of need with the median at the estimated average requirement and the recommended dietary allowance meeting the needs of 97.5% of the population. What is often missed in this is an individual might in fact have a different unique need than the RDA, but might be included in the distribution of risk and need that the framework recommends. And this is something that, as we move forward, is something important to think about. Now that chronic disease risk is formalized in this expanded model, the chronic disease risk relative to intake can have a variety of relationships. And this is a fuzzy line. It's not intended to represent simply a linear relationship. It's just for the purposes of simplifying that there are a variety of types of specific relationships. But in general, we might think about as in intake increases, risk of chronic disease increases, and sodium would be an example of this. And the chronic disease risk reduction would be set based on the evidence, and we'll talk about what type of evidence is needed to minimize or reduce that risk for the population. And similarly, you might have another chronic disease where increasing intakes decrease the risk. And some people might think that omega-3 fatty acids might represent such a relationship. And the CDRR would be set, again, to minimize the risk for the population. And there could be other chronic diseases where it's a more restrictive range with risk increasing with low and high intakes. Now, I want to move into the evidence and the nature of the evidence that's needed, because I think this is relevant to some of the issues that have been raised this morning. When we talk about adequacy, the indicator of status, biomarker, must be on the causal pathway to the clinical outcome or disease of interest. And the types of outcomes relate to deficiency disorders, but the biomarkers can relate to biomarkers of effect, of mechanism and functional outcomes, or of exposure. And there must be direct evidence of the disease and the nutrient intake to select an outcome. And there has to be a high certainty of causal inference and relationship in order to select an outcome. But this has to be also for intake relationships as well. And therefore, we are, as people like to talk about the evidence pyramid, relying heavily on randomized clinical trials, metabolic balance studies, depletion and repletion studies, although very high quality observational studies might also be included. And again, the approach now for setting such recommendations requires an examination of the totality of the evidence using a rigorous systematic review approach. Now, having said that, we actually have 12 nutrients for which we do not understand the distribution of need, and it's largely because no adequacy outcome has been identified. Under the old DRI model without the CDRR, these include total fat, omega-3 fatty acids, and omega-6 fatty acids, biotin, choline, vitamin K, and a variety of other micronutrients. Under the expanded DRI model in 2019, this also includes sodium and potassium. And I think there's a real opportunity here for precision nutrition as the research is being done to identify biomarkers and their variants. And these could be biomarkers of effect, mechanistic or functional outcomes, or exposure, and would really help build stronger DRIs for these nutrients that currently have adequate intakes. Just before we move on, DRIs for adequacy are needed because of a deficiency of an essential nutrient. They affect everyone if intake is inadequate or excessive, although has been pointed out, understanding through precision nutrition where this effect is either of inadequacy or excessive intakes might vary, and does vary by individual. It is still caused by the absence or excess of a single nutrient, and it's preventable by nutritional interventions. This is in contrast to DRIs for chronic disease. They are not warranted unless sufficient evidence is available for the nutrient or a naturally occurring food substance and the risk of chronic disease. And we'll talk about the nature of that evidence in a minute. This risk varies by individual, age, life stage, and all of the omics that we've heard. And the systems biology here is going to be incredibly important for understanding chronic disease relationships to nutrient intakes, but also in terms of the dietary guidelines to dietary patterns and specific foods. And these relationships can be relative and they can be small. They're often related to many factors that you've heard about and that interact, and they're only partially ameliorated by nutritional intervention. And again, I think there's an opportunity for precision nutrition to identify surrogate outcomes for chronic disease. While I agree with the previous speakers about the need to have clinical outcomes and the ideal nature of the specific clinical disease outcome, the reality is that it often is long-term exposure and not easy to study. So surrogate outcomes can be particularly useful. And I want to build on some of the comments that were made by Dr. Laurie about how to validate a surrogate outcome, specific in this case to a nutrient or food or dietary pattern intake. And shows here is an analytic framework in which exposure to a nutrient or a naturally occurring food substance affects a clinical outcome, and how a validated surrogate outcome can be used in this. First of all, it must be on the causal pathway, and observational and small interventional studies can be useful in determining that. It must change in concordance with changes in health outcome with specific nutritional intervention, and this is going to require rigorous clinical trials. And as a part of this, it must explain a clinically significant proportion of response to the nutritional intervention. And an outcome, a surrogate outcome, could be validated for sodium and not be validated for thiamine, and it could not be used for thiamine. And so that's the level of specificity that's required here. And finally, it must predict accurately. It must have prognostic value of the effect of the nutritional intervention on the clinical outcome in rigorous clinical trials. And this validation of a surrogate outcome was actually done by the DRI committee for sodium for blood pressure, even though blood pressure is clearly recognized as a surrogate outcome for cardiovascular disease for pharmaceutical interventions. Now, one thing that's important as we think about moving forward with precision nutrition is to think about what the guiding principles for considering chronic disease endpoints in the DRI process require in terms of evidence and how it was applied by the DRI Committee for Sodium and Potassium. There has to be at least moderate or high scientific evidence by the grade method for causal association of the nutrient with the chronic disease outcome. And the strength of evidence has to be identified for a single chronic disease outcome. This is the ideal. Thus, an integrated series of outcomes by a variety of methodologies, or an integration of a variety of outcomes all on a pathway to an outcome, are issues that are going to have to be considered as precision nutrition moves forward. It can be done with a single qualified surrogate outcome individually, no aggregation of outcomes. What happened for sodium was we had several outcomes, all of which were related to cardiovascular disease, that were considered individually, and then the judgment was made about intake-response relationship informed by all of the outcomes, but the outcomes were not aggregated in a single analysis. And therefore, for chronic disease outcome, the guiding principles recognize that the nature and substance of the evidence might be not all randomized clinical trials, and therefore well-done cohort studies and other types of studies can be included. And the nature of the evidence varies, therefore, and there's a lower certainty of causal relationship with this type of evidence, and inherently greater risk of bias because of selection, because of methodologic intakes, particularly in a variety of factors, and because of publication bias. And the grade method, just to remind everyone, is a structured way of looking at the strength of the evidence. And so RCTs start with a high rating and can be downgraded for risk of bias, imprecision, inconsistency, indirectness, and publication bias, whereas observational studies start with a low rating and can be upgraded for a large magnitude effect, intake-response relationship, and minimization of confounders. And I think there are then some opportunities and gaps for precision nutrition in terms of considering specific subpopulations. And one type of subpopulation might be a subpopulation that has a distinctly different distribution of requirement and responses. Vitamin D is controversial, whether this is the case for African Americans. The committee that worked on this did not find sufficient evidence. There are issues then that relate to dietary patterns and chronic disease risk for dietary guidelines. And this is clearly an area in which precision nutrition holds great promise for informing these type of public health guidelines, as well as developing individualized recommendations. What we've heard quite a bit about in the meeting so far is responders versus non-responders. And I want to highlight sodium and CDRR here. We've heard earlier about the increased ancestral risk for those who had interior West African ancestry. There are others that have increased risk for being sodium sensitive. And the 2019 DRI committee actually noted the need to identify sodium sensitive individuals through determining what they called rare and common genetic variants and improved methods, discovery and validation of biomarkers in blood and urine, and use of proteomics, metabolomics to increase accuracy in order to facilitate implementation of what the committee called clinical, which relative to precision nutrition would be individualized recommendations and public health settings. And this is also very important for dietary patterns and chronic disease risk. And again, the evidence is going to need to be moderate to high for both the causal association and the intake-response relationship. And I want to stress this because for potassium, there was moderate at strength evidence for the causal association with blood pressure and insufficient evidence for intake response, and no CDRR was set for potassium. An important research need that I want to highlight based on some things that I heard several speakers talk about in the first two sessions was the opportunity to have precision nutrition help us understand what's a healthy population when the prevalence of chronic disease is so high. And this could inform future studies and help us have public health guidelines for both nutrients and diet that are better informed and also understand the variance in a healthy population more specifically. want to focus a little bit on individualized recommendations using precision nutrition. And I want to raise the issue of, can individual algorithms be linked to public health guidelines? Shown in the right is the distribution, normal distribution of a nutrient requirement in a schematic fashion. One of the really big challenges in clinical practice and in dietetics practice it has been, for any given individual, up until precision nutrition has been evolving, it's been very difficult to know where that individual is in terms of their specific need. It doesn't necessarily void the public health population approach, but it makes it very hard to deal with the individual. And I think this is then raises opportunities for both the DRIs, for adequacy and chronic disease, and also for the dietary guidelines. Can, through the dietary guidelines, dietary patterns included in the dietary guidelines be tailored? And are there opportunities for My Plate Tracker if an individual knows some of their risks from the precision nutrition to actually use this? And this is a service that's available to everyone. And I think one of the big questions is what strength evidence will be required. And you've heard a number of speakers today talk about the difficulties. And so we have proof of concept, and we're emerging for some specific issues with implementable algorithms, but the strength of evidence as we move forward needs to be determined. I want to talk also about the individual recommendations and a concept, the difference between efficacy and effectiveness. And I think this may actually relate to self-selection bias of participants that in precision nutrition studies, current studies. And several speakers have been asked about bias in participation. Certainly these studies demonstrate efficacy. I was very encouraged to hear that a number of platforms and services are beginning to collect data to look at effectiveness. But the real challenge here is that the people who are coming either willing to participate in a study where they're randomly distributed, or coming because they're seeking the information. And you've heard this issue raised about what are the characteristics of these individuals. And I want to really encourage those of you working in precision nutrition to consider theories of behavior change beyond the socioecological model. It's an invaluable model, but there are other models that might be very informative to help us understand some of the characteristics of not only who's coming, but who's being successful, such as the health belief model, in which the perception of threat of health risk, benefits avoiding those risks, and factors influencing the decision to act all impact how an individual will hear and respond to coaching and to information. Similarly, with the theory of planned behavior in relationship to perceived control and an individual's health beliefs, attitudes, intentions, and behavior, the trans-theoretical model in terms of an individual's motivation and readiness to change. I'm going to submit to you that somebody that is in pre-contemplation is not going to go seek information on how to specifically improve their individual diet, nor are they going to be receptive to public health models. So these are challenges not just for individual recommendations, but for the public health approach. And finally, the precaution adoption process model, which has 7 stages from lack of awareness to action. And so I want to end by some reflections and ask some questions. How can we develop blended models that are effective and allow us to address both the population and the individual? What's the effective communication strategy? And you heard a lot about this earlier in this session. How do we ensure that most of those at risk those at most high risk have equitable access? And you heard a lot about this from Dr. Roberto today. And I just want to underscore for you the magnitude of some of these populations. There are about 26 million Americans who don't have health insurance in 2021. At least 42 million Americans are food insecure. 500,000 of Americans are homeless. And it's unclear who are the least health literate among us and what the size of that population. I also want to raise populations that we might be able to reach through federal nutrition programs, such as the 38 million SNAP participants and the over 6 million WIC participants. And I want to raise and touch on an issue that one of the speakers yesterday raised, which is how do we ensure sufficient practitioners with appropriate scope of knowledge and practice and depth of training to implement individual guidelines, and in what settings. And I think this is a real challenge for us as we move forward, and how we ensure that dietitians and other health practitioners have sufficient exposure and supervised clinical practice in precision nutrition is an issue that we need to think about. Thank you very much. I want to conclude with my thoughts about that we need to develop blended models, and that we do still need both public health and individualized recommendations, that we have a lot of opportunities for precision nutrition to inform public health guidelines and to help us have better guidelines that address key subpopulations as well, and some challenges for precision nutrition in terms of efficacy versus effectiveness and equity and reduction of health and nutrition disparities.
Wonderful. Oh, thank you so much, Dr. Brannon. And thank you to all of our speakers for those excellent presentations.